All right, chapter 10, respiration and artificial ventilation. Some of this stuff's going to be a little bit of an overlap in the last two chapters that we did. So we'll probably breeze over that. But today on this section, we're going to talk about physiology and pathophysiology, which we already touched on some of that. Respiration, positive pressure ventilation, oxygen therapy, special considerations, and assisting with advanced airway devices. All right, some physiology and pathophysiology of breathing, okay? Ventilation. When we talk about ventilation, it's the process of moving air into and out of the chest, okay? Very simple, right? Inhalation is an active process, meaning that the muscles expand, the size of the chest increase, and negative pressure pulls air into the lungs. So we're not actually sucking in air. We're creating a negative airspace in our chest cavity so that the air just pulls in. Okay, it's very important to know. Exhalation is a passive process, meaning that the muscles relax. The size of the chest decreases. Positive pressure is created, so the air gets pushed out. So we're not sucking in and blowing out. Okay, we're just manipulating the air pressure inside our chest cavity, and that's what makes the air move in and out. Okay. Couple terminology points we already hit on the last section, but again, tidal volume is the amount of air moved in one breath, that's in and out. Okay, and then the minute volume is the amount of air moved into and out of the lungs per minute. And if you remember, that's the amount of air that's moved in one breath times how many breaths per minute would be the minute volume. Okay, our dead airspace, we're talking about air moved in ventilation not reaching the alveoli. So we breathe in, not all of that air is actually going to reach the alveoli all the way in the bottom of the lungs, okay? But then there's alveolar ventilation, and we're talking about the air that actually reaches the alveoli. Remember the little grape-like structures in the bottom of the lungs, okay? Diffusion, talking about the movement of gases from high concentration to low concentration. So the oxygen is pulling out of the air into our body, and the carbon dioxide is moving out of our body, all right, and then into the lungs, and then we exhale that, okay? We have external respiration, all right, diffusion of oxygen and carbon dioxide, which is the exchange of gases we talked about, between the alveoli and the circulating blood, all right? And then internal respiration is the exchange of gases between the blood and the cells. Okay, cellular respiration, we're talking about the oxygen from the blood diffused into the cell. So now the oxygen's run around the bloodstream, it hits the cell, and it works its way into the cell. Now, that's cellular respiration. And again, that's the oxygen in, the carbon dioxide out. All right, pathophysiology of the cardiopulmonary system, we hit on this stuff. Mechanics of the breathing is disrupted, gas exchange is interrupted, and there's circulation issues. So those are some issues we can see in the cardiopulmonary system. Okay, respiration itself. How do we determine what's adequate and inadequate as far as breathing goes? I mean, are there signs and symptoms of that? Yes, there are. So we're going to have to be able to identify those. Okay, the brain and the body cells need a steady supply of oxygen. Okay, if they don't, then they become hypoxic, or they have hypoxia, which means low oxygen level in the cells, okay? Carbon dioxide must be continuously removed. We don't want hypercapnia, which would be the high carbon dioxide levels, right? Early on, steps of adjustment can meet the needs of the body despite respiratory challenge, okay? So the body can start to compensate a little bit. All right, we breathe a little faster to make up for that low oxygen level, just as an example. Okay, respiratory distress, body's compensating for a respiratory challenge and meeting metabolic needs. So we start breathing heavily or faster, okay, because there's something going on in the body that the body needs to try to overcome. All right, inadequate breathing occurs when the challenges are too great for the body's compensation mechanism. So we're breathing hard, we're trying to make up for that low oxygen level or whatever the case is, all right? And then the body just can't compensate anymore, and then we start to have more serious signs and symptoms, okay? This is also known as respiratory failure. Respiratory failure and respiratory arrest are two different things. Arrest means stopped. Failure means we are not breathing adequately, okay? It's exceptionally important to recognize that because it's often a precursor to arrest, okay? And once they go into failure, they're working towards arrest, and we don't want to get to arrest, right? Respiratory distress usually involves accessory muscles use, involves accessory muscle use and increased work of breathing. Severe or prolonged respiratory distress can proceed into respiratory failure, and then eventually it'll work into respiratory arrest, okay? Your body's getting tired out from using all those extra mechanisms to try to help you breathe, and that's the contractions in the clavicles we talked about in the last section, the retractions, the nasal flaring, all those different accessory muscles that we don't normally use to breathe, they get tired out, okay? So what are signs of adequate breathing? Relatively normal mental status, normal pulse oximetry reading, normal skin color, okay? If any of these things are off, then we're going to be suspecting inadequate breathing, okay? If they have blue around their lips, their capillary refill that we talked about in the last section is not very good, cool, clammy skin, sweaty, those are all signs of inadequate breathing. Pulse oximetry is, for those of you who don't know, there's a little device you put on your finger and it can read your oxygen saturation levels. If they get below 94, 95, we're starting to be concerned about hypoxia. It's a great tool, but always remember that a pulse oximeter is a tool and it's not always reliable. Sometimes it'll read low when it's normal. Sometimes it'll read normal when it's just carbon monoxide in the person's bloodstream. It'll say 100% oxygen level, but it's not. Okay, so we need to be able to also identify just by looking at and talking to the patient that they're breathing inadequately. Okay, chest movements can be absent, minimal, or uneven. You can see the abdominal breathing we talked about. No air could be felt or heard. Breath sounds are diminished, or you could have wheezing, crowing, stridor, gurgling, gasping, anything like that. And again, I encourage you to look up online the links to different lung sounds so you can hear what those all sound like. Okay, rate of breathing is too rapid or too slow. Okay, that could be a sign of inadequate breathing. Shallow, very deep. We have cyanosis, which is the blue around the lips. That's because the body doesn't have enough oxygen going throughout. Okay, inspirations or expirations are prolonged. Okay, retractions and nasal flaring in children. Low oxygen saturation reading on your pulse oximeter. Again, it's just a tool, so we can't always rely on those 100%, but they are a great tool to have. Hypoxia, major causes of hypoxia. Patient could be trapped in a fire. Okay, emphysema, overdoses on a drug that has a depressing effect on the respiratory system. Okay, our heroin, our opiates, too much of that will cut out your respiratory drive. Okay, and then the heart attack. Inadequate breathing. We provide artificial ventilation to the non-breathing patient and the patient with inadequate breathing. So this is where we're getting into what are we going to do for these people? Okay. When do we intervene? Often respiratory failure patients will be breathing unconscious. That means they're having trouble breathing, and we go to a lot of difficulty breathing calls. These people don't necessarily need to be have an airway put in or anything yet, but we can supplement that their oxygen a little bit. Okay, we'll talk about how to do that. Identify adequacy of breathing. If breathing is inadequate, immediate intervention is necessary. So what signs might identify the need to intervene in a breathing patient? Okay, I would look for some signs that obvious respiratory distress. So they're having trouble breathing. They look like they're having trouble breathing. All right, the blue around the lips, the pulse oximeter tool, like again, it's a tool, but it's a great tool to have. This is when we're going to be putting oxygen onto our patients. Okay, we'll talk about positive pressure ventilation. Okay, what we are doing is forcing air into the lungs when a patient has stopped breathing or is inadequate breathing. Okay, it uses force exactly opposite of how the body normally draws air into the lungs, meaning that we normally will create a negative airspace in our chest, but what we're doing is we're actually pushing air into their lungs, and we'll do that with a bag valve mask, and we'll get plenty of practice on using those. Okay, negative sides of positive pressure ventilation: decreasing cardiac output, dropping the blood pressure, gastric distension, hyperventilation. So that means we're breathing too fast for them. We don't want to do that. Okay. We want to give one breath every 5 to 6 seconds, and we will go over this with you, I promise. Gastric distension. If you don't have the airway opened right, you might be pushing air into their stomach. And if you push air into their stomach, that means they're going to vomit on you. All right. And not only that, you're also not getting the air where it belongs. Okay. Techniques. Do not ventilate a patient who is vomiting or has vomit in the airway. Okay. We got to suction that out first. We don't want to push the vomit into their lungs. Okay. Watch out for chest rise and fall with each ventilation and ensure the rate is sufficient. All right, carefully assess the adequacy of respirations, which you'll learn how to do. We're watching for good chest rise and fall on these patients. Now explain the procedure to the patient, okay? More than likely, we're not gonna be bagging alert-oriented person. It's possible, I've never done it, but it is something that we could do. Usually these people are unconscious, okay? Place the mask over the patient's nose. After sealing the mask on the patient's face, squeeze the bag with the patient's inhalation, okay? And we will talk and we will show you how this works, okay? But we're talking about a bag and we're squeezing the bag and the air is going into their lungs, and there's ways to do it and we will teach you how, okay? There's a couple different machines that are out there, CPAP and BiPAP. You have to be credentialized to use these types of devices. I don't know what departments have CPAP, but just be aware that these things exist. It's a machine that you hook to your oxygen bottle and it continuously pushes air into their lungs. And it's good for your COPD patients and that because it's continuous air. Now, when we squeeze a bag, think about this. You're squeezing a bag and you're pushing air into the patient's lungs. Great, except for then there's a lag time. So then 5 to 6 seconds, you're going to squeeze the bag again. You keep pushing air in. This is continuous, and it's lower pressure. You're not going to pop their lungs with it, but it can actually keep those alveoli inflated continuously instead of just every 5 to 6 seconds like you would with your bag. Okay. Mouth to mask ventilation performed with a pocket face mask. I've never used one of these in real life. We have a bunch of them. You guys will have the opportunity to play with. There's a little check valve on them so they don't puke into your mouth. But it's basically a little mask and you put it over their face and there's a little valve that you blow through. You can blow into their mouth. This is kind of a last ditch effort. If you're carrying around a pocket mask and you're waiting for the ambulance and they're not here with the bag valve or anything yet, you can do this, okay? And that's a picture of a pocket mask right there, a little check valve on the top there. This is where you blow in through, and that valve right there keeps the patient from blowing anything back into your face. So how do we do this? With a patient with a suspected spinal injury, what we're going to do is have the EMT at the top of the head, position yourself directly above the patient's head, apply the mask to the patient, place your thumbs over the top of the mask with your index fingers over to the bottom of the mask. So we're holding the mask onto the patient's face. Okay, we want to cover their mouth and nose, and then we're going to breathe for them. Okay, we're going to lift the jaw of the mask as you tilt the patient's head backwards. Excuse me, I misspoke. This is without a suspected spinal injury. Okay, so we're going to lift the jaw, we're going to tilt the head back, and we're going to give breaths through the one-way valve and watch for good chest rise and fall. And here's a picture of it right here. Okay, this pocket mask has supplemental oxygen going to it. That's what the little tube is. Not all of them have that. I imagine if you have oxygen and tubing, you probably have a bag valve mask. Don't go this route unless you're in a desperate situation, okay? Bag valve mask is a handheld ventilation device used to ventilate a non-breathing patient and or patient in respiratory failure. And these are some examples. They're different sizes. And we don't want to use an adult bag valve mask, or BVM as we frequently call it, on a pediatric patient because we'll be pumping too much air in and we can damage their lungs. Okay. Standard features of a bag valve mask is self-refilling shell that is easily cleaned and sterilized. There's a non-jam valve that allows an oxygen inlet flow of 15 liters per minute and a non-rebreathing valve. So this device, you squeeze it and it self refills, and there's an oxygen port on the back, and we hook oxygen to it, and we set it at 15 liters per minute. These will be test questions. You will be asked frequently throughout skills nights, what is a bag valve mask set at for when you hook oxygen to it? And the answer is no less than 15 liters per minute. Okay, the mechanics, they supply 15 liters per minute of oxygen, attaches and enters reservoir. When squeezed, the air inlet is closed and oxygen is delivered to the patient. When it's released, passive expiration by the patient occurs. So you're going to shove the air into their lungs, and they're going to automatically just exhale it. Okay? How do we do it? Two rescue or BVM ventilation with no trauma suspected. Okay, this is strongly recommended by the AHA. Most difficult part of BVM ventilation is obtaining an adequate mask seal. We'll teach you how to do that. What you want to do is you create a C with your hand. And then that C on your hand between your thumb and your first finger, you're going to be pushing the mask down on that. And you're actually going to hold on to the patient's jaw a little bit to keep that seal. And as you squeeze, all the air ideally will go into their lungs. Okay? Two rescue or BVM ventilation basically means that one person's holding the mask on and the other person is squeezing the bag. This doesn't happen very frequently, really. It's a lot of times what we do is one rescue or BVM ventilation, and that's okay. We're going to teach you how to do that. It can be done with one person. It's a little easier with two, but it's really not that big a deal if you have to do it yourself because somebody else is probably doing something else. Now, unless you have a lot of set of hands, especially during a cardiac arrest where you're doing CPR, you're probably going to have one person doing compressions and one person doing bag valve, and that's okay. All right, so we talked about all of this. Here's an example right there. One guy holding the mask down. We have the other person squeezing the bag. This all can be done by yourself. One rescue BVM. I already talked about this. We're going to form the C, squeeze the bag, exhale. If the chest does not rise and fall during BVM ventilation, you should reposition the head. Check for escape of air around the mask. You can hear it usually coming out of the side of the mask a little bit if you don't have a good seal around their mouth and nose. All right. But reposition the head because it might be going into their stomach. You want to check that C fist there to make sure that you got a good seal on the mask. You can check for an airway obstruction. Okay, artificial ventilation of a stoma breather. So you have somebody with that stoma in their throat. Okay, we want to clear the mucus plug or secretions from the stoma. So we're going to suction that out if we need to. Leave the head and neck in neutral position and use a pediatric size mask to establish a seal around the stoma. So because it's smaller, the neck's smaller. So you want to use a smaller mask because let me just go back here. This mask on here where the one rescuer is holding the mask down, those will pop off your bag valve mask and you can change them. They're different sizes. So you want to use a smaller one for the stoma. Okay. Ventilate at the appropriate rate for the patient's age. So generally speaking, normal adults, you're going to ventilate at a rate of one breath every 5 to 6 seconds. And if unable to artificially ventilate through the stoma, seal the stoma and attempt artificial ventilation through the mouth and nose. A lot of times they excuse me, I lost my train of thought. A lot of times the stoma is there. I mean, obviously it's there for a reason. There might be a block in the upper part of the airway, but if you can't bag this person through their mouth and nose, or excuse me, through their stoma, we might try to do it through their mouth and nose. Flow restricted oxygen powered ventilation device. This is something that is not required as part of Part 800, but it is a device we need you to just be aware of exists. I don't actually know anybody who has one, but you may get one down the road. So just know that this thing exists. It's a little mask that you push the button on it and it pushes oxygen into their lungs through their mouth and nose. And we'll show you one. We have one at the college, but we can only use it on adults. We follow the same procedures for a mask seal for the bag valve, and we trigger the device until their chest rises. So you put this mask on, you push the button, and it pushes high flow oxygen into their lungs. The problem with these things is that if you're not paying attention, real close attention, you might overventilate, and that's why it's used on adults only, because it's very easy to do it to a pediatric. So it's really not, this is not a very commonly used device, but there's a picture of it right there. See, it's got the nice seal on there, and he just pushes that little button there and it shoots oxygen in. Importance of supplemental oxygen. Issues to consider when making decisions about oxygen administration. Oxygen is a drug, okay? Oxygen can do harm. Oxygen should be administered based on your overall evaluation of the patient's presentation and possible underlying conditions, okay? We don't want to give oxygen to people who don't need it. There was a time that everybody's like, oh, just put them on oxygen, put them on oxygen. And then they kind of determined that oxygen can do some harm. So we don't give it to people who don't need it, but it is very commonly given, you know, and it increases the flammability also. So some patients, we've had patients where their clothes will get saturated with oxygen, and you know, they'll light up a cigarette and they catch on fire because their clothes and everything just makes it that much more flammable. It's not a flammable gas itself, but adding oxygen to anything makes it more flammable, if that makes sense at all. So oxygen can be very dangerous. We don't give oxygen around people smoking, anything like that. It can be very, very dangerous, okay? Oxygen therapy equipment, it's portable. It's in the field. We use it in the field. Lightweight, safe, and it's dependable, okay? It's installed inside the ambulance also. So we have a big tank in the ambulance. We have small tanks on our stretchers, sometimes in our jump bags, things of that nature. All right, there's a couple of examples. We will show you guys how to put these together and how to use them properly. Okay, they come in various sizes. D cylinder is about 350 liters of oxygen. E cylinder is 625, and an M cylinder is around 3,000 liters of oxygen. Those are the big tanks you see that are mounted in the ambulance. Okay, we're not going to carry around an M cylinder because they're huge. Okay, but we might carry around a D cylinder or even an E cylinder. I think that's an E right there, and that's a D. These are the common ones right here that we usually carry. There's a good amount of oxygen in there. It can get you through a call or two, depending on your transport time. G and H, they're bigger and bigger tanks. Connected pressure regulators, connected to the oxygen cylinder to provide a safe working pressure of 30 to 70 PSI. Okay, and then flow meters. So we have a regulator that goes onto the tank, and from there, off of that regulator, we have a flow meter. They allow control of the flow of oxygen in liters per minute. Okay, that's how we measure our oxygen deliveries, in liters per minute. Okay, we have low pressure flow meters, pressure compensated flow meter, constant flow selector valve. And that's what's most common. We have high pressure flow meters for CPR devices, respirations, CPAP and BiPAP devices. Let me back up just a couple slides here and show you guys something. Okay, that's a little regulator right here. That little port right there. You put your oxygen tubing onto that, and this little dial right here, you can set up to, usually it'll go up to 25 liters per minute. This is how we're going to administer oxygen for the most part. If you get into a CPAP machine or the flow restricted oxygen powered ventilation device that I talked about, you need a high pressure port. And some of these regulators have a little port right here that you can connect to that'll give you more pressure than that. But for the most part, we're using the low pressure flow meters. And we will show you all of this stuff. Well, here's some pictures right there. I didn't realize we're on here. Okay. And there's a dial right there. This is how you set. That's 4 liters per minute, 6, 10, 15, I think that says. This gauge on the front will show you how many pounds of pressure are inside your tank. There's another example right there. This is the high pressure port I was talking about. Some regulators have. And then this right here has a dial on the side where you can change this one up to, usually it's up to 25. Humidifiers. Okay, we don't use humidified oxygen very often, but it is a thing. It's a little bottle of water, basically, that we can connect to the flow meter. It provides moisture to the dry oxygen coming from the supply cylinder. They say you can use this mostly on pediatric patients or really, really long transports because the oxygen you're giving your patient will really dry out their airway pretty quickly. I've never administered humidified oxygen before. Some of you may have, or some people in your departments may have. It's really, nothing says you have to use it here and then. So there's just an example. Sterile water goes in through your flow valve. Okay. Hazards of oxygen therapy. All right. So oxygen is a highly compressed gas. And if you break the valve off a tank, the supply tank can become a missile. Okay. It's got a lot of pressure in there. And if you shear that valve off, it can go flying and really hurt somebody or kill somebody. Okay. So we need to protect that bottle. Okay. They're durable. Don't get me wrong. They don't just shear off very easily, but it can happen. So be aware of that. Okay. Oxygen supports combustion, as we talked about. It can saturate towel sheets, clothing, all kinds of stuff. Okay. And oxygen and oil do not mix under pressure. So that's why we need to be careful with our water-based lube for our airways that we talked about. You don't ever use oil-based lube to lubricate your regulator or anything like that, because the two of them react to each other. Okay, rare medical conditions. Oxygen toxicity or air sac collapse. Never seen this happen before. Apparently it's possible. It can cause damage to infants' eyes. It can cause respiratory depression or respiratory arrest. It can, in very rare cases, with a patient with COPD history, and it knocks out their respiratory drive. These are really not things, we are not going to hold oxygen from somebody who needs it, but these are things that can happen. They're highly unlikely, okay? Administering oxygen, work with your instructor, follow your instructor's directions to understand how to use the specific equipment. There's lots of different devices available. When we meet in person next time, we'll put our hands on all of this stuff, okay? So now we're on to our non-rebreather mask. This is probably the most common type of oxygen delivery device. The best way to deliver high concentrations of oxygen to a breathing patient, okay? This is just the easiest way to do it. That's a non-rebreather mask. There's little discs on the side so that when the patient exhales, their air that they are exhaling comes out of those, so they don't rebreathe their same air. Does that makes sense? Okay. Non-rebreather mask provides oxygen concentrations of 80 to 100%. Optimum flow rate is 12 to 15 liters per minute. And new design feature allows for one emergency port in the mask so that the patient can still receive atmospheric air should the oxygen supply fail. So what that means is that, let's say your oxygen bottle goes empty and you're not paying attention, which I never want to hear you guys in that situation. You should always be paying attention. It's not going to suffocate them. They're going to be able to breathe out through the mask, just regular atmospheric air. Okay. And then we have our nasal cannulas. Best choice for a patient who refuses to wear an oxygen face mask. So if a patient refuses the non-rebreather, some people can think that this is kind of restrictive and suffocating. So we want to go to a cannula then. It doesn't provide as much concentration of oxygen, but it's supplementing. It's better than nothing. Okay, and this is a nasal cannula here. So this is the little tubes that go in the nose. This wraps around the ears of the patient. This connects to your oxygen bottle. Okay, the concentrations are between 24 and 44%, opposed to the non-rebreather that was 80 to 100%. So again, they're not getting as much oxygen as they may need, but if they refuse to wear a mask, then we can go this route. Okay, the flow rate on a nasal cannula is no more than 6 liters per minute. So when you get asked the flow rates for a nasal cannula, no more than 6. Non-rebreather is 12 to 15, and a bag valve is 15 or more. Okay, a couple special considerations. Ventilating the intubated patients. Paramedics might be putting a tube down the patient's throat. Okay, I don't know if there's a picture coming up or not, but it's a tube that's a permanent airway, semi-permanent airway, I guess. And our bag valve mask will actually click right onto the top of that tube. Okay. We are going to ventilate at the same rate of every 5 to 6 seconds. The good thing about this is we don't have to mess with their head at all. We don't have to make sure it's going into their lungs and not their stomach. The tube's already placed, and all we're doing is just pushing air into their lungs. Okay, quick chapter review. Respiratory failure is a result of inadequate breathing, breathing that is insufficient to support life. A patient in respiratory failure or respiratory arrest must receive artificial ventilations, meaning we have to breathe for these people. Okay. Oxygen can be delivered to the non-breathing patient as a supplement to artificial ventilation. Whoops, I skipped one there. Oxygen can also be administered as therapy to the breathing patient whose breathing is inadequate or who is cyanotic, cool, and clammy, short of breath, suffering chest pain, suffering severe injuries, or displaying an altered mental status. We want to give the oxygen to people who need it. I would disagree probably with the severe, it depends. All these people could get oxygen, but we don't really know if they need it. So if they need it, they're inadequate breathing, then we want to give oxygen. Okay, remember, always use proper PPE when managing an airway. Assessment of the breathing must be an ongoing process. Respiratory status can change over time, and it can change very quickly. Okay, and inadequate breathing requires an immediate action. All right, that is it for chapter 10. I will see you guys soon.